Okay, so thank you everyone for joining us on this conversation about interferon gamma-mediated diseases. My name is Pui Li. I'm a pediatric rheumatologist at Boston Children's Hospital. I'm also assistant professor in pediatrics. Joining me today are Dr. Kumar and Dr. Khanna, and I'll let them introduce themselves.
Scott Khanna at Children's Hospital, Philadelphia.
Ashish Kumar, Cincinnati Children's Hospital.
Hey, nice to have you both. So during this segment, we're going to discuss the role of laboratory testing and diagnostic evaluation on these diseases that are related to interferon gamma. And so the learning objective for this section is to develop some strategies, incorporate rapid point-of-care testing to improve the laboratory processes to expedite the diagnostic evaluation and treatment of these conditions. So when we think about interferon gamma-mediated diseases, where we're talking about life-threatening cytokine syndromes like HLH or macular activation syndrome in the world of rheumatology, and also malignancy associated HLH and many others, these really dangerous conditions that could result in very different outcomes if treatment was started just a few hours earlier. So the goal, of course, for all of us is to find specific tests, right, that can recognize conditions, to make diagnosis quickly and start treatment. And so first, let's talk about some of the tests that are available, right, that's widely available through the clinical settings and most physicians have available to them. And so these are also incorporated in many of the recognized criteria, diagnostic criteria for HLH and MAS that we have discussed in a prior session. So some of these things like CBC differentials, right, gives you the cell counts, right, specifically platelets. That's often one of the first markers to decrease in HLH MAS. We have ferritin, right, is a good marker that macrophage release in a setting of inflammation. And when it gets to very high levels, it seems to be favoring diagnosis of HLH MAS. We also have a number of other markers. Soluble IL-2 receptor, for example, is often a good marker for the activated T cells, which is another sort of common feature of these conditions. We use transaminases, ALT, AST, ALT, that suggest hepatitis, of course, not specific to the condition. And then we have numerous other labs, and we can look at fibrinogen decrease, set rate decreasing in that context. LDH is increasing as a marker of cell turnover. We also use triglycerides and D-dimer. The latter one is more of a marker of coagulopathy that we see in these conditions. So these are all good markers, especially when you use them in combination. And for many years, right, clinicians have been using these diagnostic criteria, which comprises of a combination of these markers, of course, right, to make these very difficult diagnoses sometimes. But the challenge, of course, is these available markers of inflammation, if you will, are not particularly specific, right? In each of them, we can certainly find many other conditions that could have elevated levels beyond the normal range that is not due to HLH, MAS, or related conditions, right? So other causes of inflammation can give you elevation of these labs. So that makes it somewhat difficult, right? We don't really have, for a long time, don't have very specific labs to help us with these conditions. But I think if you have to pick one of these, I think the one that we recognize a lot is ferritin. It's fairly available throughout the world. And I do think to this day is still a fairly good marker. And I know, Dr. Khanna has, some comments about this because his lab works on a bit with ferritin. So what do you think?
I think for all of our bluster about new biomarkers, we haven't found one that's a lot better than ferritin. As we've discussed, it's not real specific for the syndrome of HLH. Ferritin is, I think of ferritin as sort of having two things that bump it. One is inflammation, and probably the kind of inflammation that leads to HLH or maybe a more interferon gamma-driven inflammation. And probably that's because of macrophage activation. And maybe the best evidence for that is that the kind of ferritin that comes out during inflammation is low glycosylation, which is maybe because it's being sort of forcibly ejected or released. And then there's iron itself. So patients that get a lot of blood transfusions or iron overload often have a non-inflammatory hyperferritinemia. And I think clinically we have seen those two things sort of interact, where we might have a patient who has a high ferritin because of sickle cell or whatnot, who then has an infection or whatnot, and the ferritin goes, way higher than you might otherwise expect because those two things are at work. But all of the criteria use ferritin. I think it's conspicuous that the criteria for like primary HLH or for MAS use a relatively low threshold of like 5 to 600, whereas the criteria like the H score, which are maybe more intended for adults who might have chronic disease or malignancies, it's a point system, but you don't really get a lot of points until the ferritin's much higher. And so, you really have to put the ferritin in the context of the what you might expect of that person, what their ferritin might be if they didn't, have this HLH as sort of their starting point. But I think you have to measure it in order to interpret it. And we just did a study where we had a hyperferritinemia alert. And one of the big takeaways is that the ordering patterns in my institution are dramatically different than at Dr. Kumar's institution. My institution's intensive care unit is loopy for ferritin and sends it all the time, for better or worse. And Dr. Kumar's hardly ever sends it. And so, your local sort of gestalt or invoking terms like HLH really depends on when you send it. But I mean, consistently, if you enter an ICU and you have a higher ferritin, you're less likely to leave that ICU. And I think that reflects just sort of a global predisposition to damaging inflammation.
And I agree with that. In fact, there are historical data that show that ferritins, at least in the adult ICU world, elevated ferritins were found in up to 70% of patients who ended up not surviving. So a high ferritin does correlate with severe inflammation or severe organ damage for that matter, because we know that dying cells will also, the more cells that die, the more ferritin you will have abundantly evident in the circulation. So while I agree that I do think ferritin is, the beauty of ferritin that is readily available, almost every medical center can measure it. It is extremely sensitive, so it's a good starting point. But I don't think it's enough for us to, which we often see is that, the ferritin is high, it must be HLH. No, I think if the ferritin is low, yes, I think it has a much better negative predictive value when it is normal.
Yeah, and absolutely agree with that. I think it's a test where when we think about HLH-MAS, we're not thinking about, just, above the normal limits of a few hundred nanograms. We're talking about like thousands, if not tens and hundreds of thousands, sometimes above the measurable scale, right, in the institution. So,
right. And I think that's the one other thing that I would mention, that I think folks who don't normally order ferritins, they start panicking when they see the ferritin of 2,000. Because the upper limit of normal is listed as 30 or something, and then you see 2,000 and you start panicking that this must be HLH. Whereas for those of us who do it on a regular basis, exactly what you said. I think that there should be availability, also familiarity with the dynamic ranges of all these assays that we're measuring.
But nevertheless, it's not a super specific test. We've certainly seen cases for liver disease and other places where there's no HLH, but ferritin gets very elevated because of a clearance issue. So, but ferritin has been around for decades, right? It's really a sort of a good marker. But now, fast forward to 2024. Now that we know a lot more about the biology of HLH and its related conditions, and so we can think a little bit more about the molecular level in terms of the immunology behind it, right? Thinking about interferon gamma as one of the key cytokines that drive this process. So specifically, we're talking about T cells, right? Activation, releasing interferon gamma that drives the cycle of inflammation. So it seems like an obvious thing that, maybe we can measure like cytokines, right? Like interferon gamma in the context of diagnosing HLH-MAS. But maybe it's too simple, right? We do have these cytokine panels, and some places there's a send out. In my institution, we send it out, which, of course, becomes a challenge. If you send out tests and it comes back after 3 days, is that really a good, test that you want to diagnose a condition where the patient can die within, hours? And are the cytokines that often they measure a number of them, like the 12, 13 cytokine panels, interferon gamma often is included. But in our experience, it's also, when it's really high, you can pick it up. But if it's not very high, it's often, sometimes you see it, sometimes you don't see it. And then there are other markers that are cytokines that comes back that, we don't know what to do with. Like we have high IL-6 that's often seen, but that's often just generalized inflammation. We can see that reflecting your C-reactive protein. We see high IL-10 that also just reflects general inflammation, although we see it's high often in HLH also. What do you guys think in terms of your institution, your practice of cytokine panels, and do you find that useful? Start with Dr. Canna.
We do. I'm maybe not as bullish on our cytokine panel as some of my colleagues, but we certainly send it a lot. We are fortunate to have a panel that we run in-house that is quite sensitive. And we've done this a number of times where an interferon gamma level on our assay will be elevated and will be normal if it goes to, the same sample goes somewhere else. And so I would say, one, you kind of have to know your panel and what the sensitivities are. And two, the highest thing is not the thing that necessarily needs to be blocked. I think it's a little bit more like reading tea leaves. The cytokine panel of HLH is canonically a lot of interferon gamma, a lot of IL-10, maybe not so much IL-6 and TNF, and IL-8 is a little bit of a wild card. And that has sometimes been useful in sort of reassuring us diagnostically. And also, we've had patients who we have seen that panel, found that they had a primary HLH, and then they had a complication later, and we repeated a panel, and it was a pattern that was totally different of really a lot of IL-6, 8, TNF, very little gamma and 10, and 2 days later, blood culture grows positive, and so I think it's another piece of information, but turnaround time and having some familiarity with your panel are probably pretty critical, and so I think we're all still trying to figure out the best use of these.
Yeah, and for Dr. Kumar, on the heme side of things, how do you guys utilize cytokine panel?
Yeah, so to some extent, we're in a similar conundrum. And again, there's differences. I personally don't find much utility in getting the whole panel because I don't know what to make of an elevated IL-8 and IL-10. And the IL-6, I can just measure a CRP that gives me the same information. And, okay, Dr. King, for the most part, fine. But it's interferon gamma that we're most interested in. What we find is that, just like you said, the dynamic range of measuring interferon gamma itself, the dynamic range is a little narrow. So interpreting that became a little bit of a challenge. And this is where we now have the availability of one of the downstream chemokines of interferon gamma, and that is CXCL9.
Correct.
And I'm stealing your thunder by jumping to that right away, that we utilize that in a similar fashion as Dr. Canna would utilize interferon gamma. And again, it's one of the assays that is not universally available everywhere. We just happen to be fortunate that it's available at our institution. And so when we see an elevated ferritin, cytopenias, and liver inflammation, the next thing we get is CXCL9. And just like we were talking about ferritin, we have to become familiar with what is the HLH range of CXCL9 and what may be slightly elevated. And if the CXCL9 is definitely very, very high, then I think that clinches the diagnosis of an interferon gamma-driven disease, whether it is primary HLH or MAS, that depends, but regardless, we know that it's going to be one of those. And just like Dr. Canna mentioned, that after we started therapy and all of a sudden the patient's condition changes, we look at the CXCL9 again. If the CXCL9 has gone up, then we think that the disease is escaping our treatment. On the other hand, the CXCL9 is still going down, and the patient's condition is not correlating with that. Then we say, perhaps it is something else, and that is where things like infections become available. We start searching for complications like infections. And so the newer player in this arena is currently CXCL9 or interferon gamma if you have it available.
Yeah, I think the dynamic range of CXCL9 certainly has a great advantage here, and also in the context of treatment, right? I think, and often this is a common problem with cytokine therapy, right? If you block interferon gamma, your interferon gamma level actually goes up, right? Because the often cytokine assay would capture the stabilized complex, and so same thing with TNF and other. So from a sort of therapeutic standpoint, this may be more helpful. Another marker that people often talk about in this context is interleukin-18, right? So we see this in rheumatology is playing out, especially in kids with systemic GIA or Still's disease, where they often have pretty high levels of IL-18 to begin with, and then when they have MAS, which is a secondary form of HLH, it goes even higher, right? So the astronomical levels, which you often see very high levels in HLH as well. So it's another marker, but I think the interpretation for that one is somewhat different in my mind, because you often started with much higher baseline, right? So Dr. Kenna, you work on IL-18 as well, some mouse model to go along with that. How do you think about IL-18 in this context?
Well, I think the world of IL-18. I think that it is unique in every other biomarker that we'll discuss, in that there's some real diagnostic specificity here. In that you just don't see levels above, to be conservative, 40,000 picograms per ml outside of patients with Still's disease or Still's systemic GA MAS. Now, it doesn't tell you if they're in MAS. It just tells you kind of you're in a ballpark of a patient that likely has Still's or one of the very rare genetic diseases that has been a sort of associated with Still's, XIAP and LRC4. And so, by contrast, if you have a patient who has all the features of HLH and you send an IL-18 and it's pretty minimally elevated, you can, in a lot of ways, rule out MAS or systemic GIA Still's, because it really should almost universally in those patients have IL-18s that are, and we've seen levels 500,000, 600,000. My level is consistently around 300-400. So the magnitude is massive. But after the diagnosis, I don't know that IL-18 in an acute setting is that helpful. You've said it, it's either really high or not so high. We don't tend to track it, certainly very frequently, because its dynamics are not particularly useful in the way that CXCL9, we haven't talked as much about soluble IL-2. Those are both, less diagnostically specific, much more helpful for monitoring.
Yeah, and I would agree that I think the combination of IL-18 and CXCL9, one, a sky-high level of IL-18 combined with very high levels of CXCL9, it's almost diagnostic for MAS, most likely in systemic onset GIA. On the other hand, if the CXCL9 is very high, but the IL-18 is only minimally elevated, and you are suspecting HLH, then you go more towards it's less likely to be MAS and more likely to be primary HLH. So there is a significant utility in measuring both of these new biomarkers, IL-18 and CXCL9, for making the diagnosis and the distinction. And then the CXCL9, as Dr. Kanna mentioned, yes, it is very helpful in monitoring response to therapy, because it's a direct marker of interferon gamma activity. And whatever treatment you are using in an interferon gamma driven disease, whether your treatment is working or not, the CXCL9 is a very sensitive biomarker of that.
Yeah, and just to round out the discussion on the T cell component of this, right? Because sorry to cut you off. So
no, I think that's very
soluble IL-2 receptor is another marker that Dr. Kanna mentioned that's been used for some time now. It's thinking about shredding from activated T cells, right? But from my work and also work with others, where we're also now looking at specific T cell profiles, right? So looking at these population activated T cells, often characterized by expression of CD38 and MHC class 2, where it's quite specific in the context of HLH-MAS compared to other sources of rheumatic disease, for example, where we do see immune cell activation. But time will tell whether those will be developed as a good diagnostic marker or more of a monitoring marker in the long run.
But I guess to our point earlier, that panel of CD38 and that activated T cell profile is not unique to primary HLH and MAS.
Correct.
In infection-associated HLH, maybe
Totally agree.
even in malignancy-associated, you see some of those same patterns. And so there may be a convergence and this idea of a secondary HLH may be a real thing. I think it's also worth mentioning that, like, outside EBV, it's not every infection that equally leads to infection-associated HLH. It tends to be intracellular infections, be they dengue virus or ehrlichiosis
or
TB.
Yep.
Right? It's things that are inside cells, which are really the kinds of things that type 1 immunity, interferon gamma, CD8 T cells are sort of purpose-built to attack. And so, I think the soluble IL-2 is maybe a more crude readout than the CD38, HLA-DR, however you want to describe them, T cells, for what we truly mean as HLH, as opposed to a patient who has hyperferritinemic sepsis but is not a T cell driven process. It's just everything's shutting down. They meet criteria, but we're not talking about a T cell driven disease. We haven't mentioned CAR T cell CRS at all. And I just want to point out that I think that that's another great illustration of having a starting point for what you expect biomarkers to be, because we're often flabbergasted at what the ferritin levels and the soluble IL-2 levels are in CRS patients.
Yes.
Because they're, 50,000 ferritin levels and, just stratospheric. And perhaps in part because those patients have often refractory cancers, they're getting transfused. So their starting point is much higher already. And so, like, I think the trends in these biomarkers are important, but maybe Dr. Kumar, you can comment more on sort of how these things play out in situations like CRS.
Yep. Before I get to CRS, this is the one point you and I completely agree on, and that is markers of T cell activation are important in differentiating, are we truly dealing with a mimic or a real? And these, whether it's a soluble IL-2 receptor, HLA-DR, or CD38, those have very high utility as negative predictive markers again. So if they're normal, you can say this is not an HLH-like disease. And as far as CAR T cells, yes, these are activated T cells that are being purposely activated to go and seek out the cancer. And they become more activated once they come in contact with the ligand. The best example of that is the CD19 targeted CAR T cells that are going after either a B cell leukemia or lymphoma. And as soon as they encounter their ligand, they become super activated, which is their job. In that activated state, depending on how activated they become, and that some of it depends on how much cancer they have to wipe out, they will secrete vast amounts of other inflammatory cytokines such as IL-6 and then even interferon gamma. And sometimes the patient's clinical state, their organs are able to tolerate the amount of IL-6 and interferon gamma that is being secreted. But at other times, it causes significant organ dysfunction that looks identical to what we see in patients with the HLH or MAS, where they are very, very febrile and they start developing organ dysfunctions such as the liver cytopenias, and including central nervous system dysfunction. And all of these are driven by the same inflammatory cytokines that we see in MAS and HLH. So that's a newer, truly secondary form of HLH that is iatrogenically driven. But the underlying basis has some of the similar cytokines, such as interferon gamma, that we see in primary HLH and MAS diseases.
Yeah.
And so these markers, the same ones, ferritin, CXCL9, become useful in differentiating if we have a patient who's just received CAR T therapy and they start having fevers, are they having an infection or are they having a cytokine release syndrome? I think these markers help us in that situation as well.
I think that's all excellent point. And we really have this nice conversation about many different markers that are available. I think one of the key points that we can all agree on is having these tests available as a rapid test, right? Getting the results back on the sooner side is what makes them useful, because if you get them
Exactly.
several days later as a sent out test, the utility is much less, I would say, right, in terms of using this for an acute condition. So I think that's that's to the point where we also have to work with the laboratory medicines and institutions to try to introduce some of these really important tests, because many places still don't have this. I think we're all fortunate to be in large tertiary centers where these are some of these options are available. But for the large majority of physicians out there, these tests would be great to have to facilitate diagnosis as well as monitoring of these conditions.
But let us not let our audience throw their hands up in despair, because that's just not, if your lab can send out tests, they can send out these tests. And I know that because we send my lab works on nothing but IL-18. We send our clinical IL-18s out to Dr. Kumar's institution for right now.
We do,
and we still, find them incredibly valuable and useful. And so our audience has the same access to these tests as we do. And yes, it would be great if we all had them in 24-hour turnaround time. And hopefully that's coming. But, you have access to these. And so, your patients deserve to benefit and be managed the same way ours do.
And my understanding is there are also commercial entities that are developing these tests, so they're becoming more available. And so it's not.
But I agree with Dr. Khanna that we physicians, our clinician colleagues, that just because they take a little longer, should not shy away from getting these tests, and in fact should demand that the institutions figure a way out, come up with ways to get the results. And speaking for our institution, if the samples come and people reach out, we can, when I say we, I mean our colleagues in the laboratory of medicine usually can get them the results in a reasonable, hopefully useful time frame.
Okay, so with that, I'd like to wrap up this session on biomarkers of interferon-gamma-driven diseases. I'd like to thank my colleagues, Dr. Kumar and Dr. Khanna, for this discussion. Thank you for joining us for this segment, and please click on this landing page for this activity to claim your CME credit.